I want to welcome everyone to InCHIP's series of panel discussions on COVID-19. This is the third in our series, and it's focused on the impact of COVID-19 on vulnerable and at-risk populations. Our fourth and final panel discussion for the year will take place on November 12th at 12:30. We're going to have three presentations about the effects of COVID on child caregivers. So for those of you who have not participated in any of these panel discussions, I'll tell you briefly how they came about. Last spring, we invited researchers to submit proposals for rapid release fund for COVID-focused pilot projects, and we ended up funding 20 very diverse and innovative projects. The panel discussions are an opportunity for you to hear about the preliminary findings from these really exciting studies. Today, there's going to be 5 brief presentations, and that's going to be followed by a Q&A period. We ask that you remain muted, please, throughout the presentations. We're going to save all questions until the Q&A period, or you can enter them into the chat throughout. Very happy to welcome our first presenter, who is Yiru Wang, who is an assistant professor in the School of Business at SUNY Oswego, and also one of the co-PIs on this project. There are 3 additional co-PIs. This is a truly interdisciplinary project. Peter Chen, who's an assistant professor in geography, Deb's Ghosh, also an assistant professor in geography, associate professor in geography, and Marlene Schwartz, who is another one of the co-PIs. She's a professor in HDFS and director of Red Center for Food Policy and Obesity. And one other team member is Rong, who's assistant professor in allied health sciences. The presentation is entitled COVID-19 and Retail Grocery Shopping Preliminary Insights from a Broad-Based Consumer Survey. Go ahead, Yiru.
Okay, so everyone hear me all right? Okay, so my name is Yiru Wang. I'm a second-year assistant professor of marketing at SUNY Oswego. And in this particular presentation, I'm going to talk about COVID-19 and retail grocery management. And our study is based on a broad-based consumer survey. And since Deborah has just introduced all my co-authors for me, so I'm just going to slide this through. Okay, so So the agenda of this presentation is including 3 major sections. First, starting from background and project pipeline. Then we're going to cover the methodology part, including survey questions and sample structure. And then I'm going to talk about the findings and implications briefly about 2 thoughts. The first one is about in-store grocery shopping trend during COVID-19. And the second one is about the beginning of a long-term transition to online grocery shopping. Okay. So why are we doing this particular study is basically because we're recently viewing a lot of changes in the retail sector in the entire United States as well as across different countries. So basically in terms of retailing, many sectors are experiencing a large downfall in terms of apparels, dining, and cruises, airline companies, things like that. However, we are seeing several outliers, including the takeout business as well as the grocery shopping in general, including grocery deliveries. And we're trying to explore what kind of perception changes and behavior patterns changes in those growing sectors, including grocery delivery, which is online delivery, and the in-store grocery shopping. So that's the basic motivation for this particular study. And we collected a very large set of sample, and we're trying to supply 3 studies in the same pipeline, using the same set of respondents. The current presentation, we're referring to the research pipeline project number 1, talking about evaluating the changes in grocery shopping before and during COVID-19. And some ongoing research, we're also working with food secure and insecure consumers' expenditure in-store in terms of COVID-19. And then we're also talking about how COVID-19 has reshaped people's activity space using grocery shopping as an evidence. So in terms of methodology, as I mentioned before, this is an online survey, and we launched the survey through Amazon Magnifica Turk in May 2020, and MTurk is a widely used survey distribution channel in many fields, including psychology, business, and many other fields. And the survey is created by Peter Chen, and we have over 70 questions in this particular survey, and we're asking questions to individual respondents about their grocery shopping during the early outbreak. We also asked the participants to recall their grocery shopping trips in 2019 as a comparison, as a control group, in health terms. And we have collected over 2,500 respondents in this particular survey data collection process. And the survey questions are mostly in 4 sections. We ask questions in terms of consumers' grocery shopping practice and perception changes during and before COVID-19. We ask consumers in-store grocery shopping questions to very little detail, including their location, store type, timing, distance, travel modes, frequency, and expenditure during the shopping before and during COVID-19. And we also ask questions in terms of online grocery shopping experience during COVID-19 as well. At the end of the survey, we include questions including demographic questions and socioeconomic questions, including people's age, ethnicity, income, employment status, education, marriage status, and things like that. So those are the overview of the survey questions. And in terms of the sample structure, we collected 2,590 respondents overall, but we used several attention check questions to filter the respondents to make sure the respondents are of really good quality. So at the end, we got 2,429 respondents, and we used them for the data analysis. So in terms of the sample structure, more than 40% of the survey respondents were female, and 44% is among the 25 to 34 age group, and 70% of the respondents were Caucasian, 14% of them are African American, and we also have a portion of Asian and Latino Americans. And most of the sample respondents declared to being in a marriage relationship, and most of them having a college degree or above. And then we find 60% reported they have been employed for wages during COVID-19, and 45% declared an annual income of 40K to 80K during the fiscal year of 2019. So in my personal opinion, I think the sample is overly overall representative in terms of the US population, but it's kind of skewed towards the educated and younger population because of its online survey distributed through Amazon Turk. You need to have an account on Amazon Turk first. So that's the sample structure. And in terms of findings, we're going to introduce you the in-store grocery shopping change during COVID-19 first. So first about grocery shopping frequency and time. We're observing that during COVID-19, many people are reduced their frequency to go to grocery shopping in-store. Before COVID-19, we're talking about once a week, 2 or 3 times a week. And we're seeing a lot of change towards, once a week or 2 or 3 times a month, something like that. So in general, people reduce their frequency to go to grocery shopping. And in terms of time windows, we're observing a lot of shifts to the morning hours. For example, many people were who are used to shopping at noon, in the afternoon, and in the evening times, they're now moving to an earlier time range. So therefore, the implication would be the retail stores should think about changing their operation schedule. For example, have more food in stock earlier and have less or fewer employees working in the night shifts. And other results we're observing is the consumers are reducing their time wandering in the store during COVID compared to before. And a very important finding is that they perceive in-store shopping as less safe compared to the before COVID times. And a very general finding in terms of expenditure per trip is actually people are spending more per trip nowadays during COVID-19. This is kind of intuitive in general because people are reducing their frequency to go to the store. However, a following up study, the second one in our pipeline, we actually find that this only applies to the food secure people. For food insecure population, people are actually spending the same or similar to their expenditure before COVID-19. So this is just some additional information. And then in terms of different store types, we're saying that we're categorizing all the grocery stores in the US to 6 categories, including farmers market, ethnic food store, convenience store, wholesale club, national and local chain stores. And we're seeing that the chain stores, no matter at national level or local level, we're seeing they're maintaining or retaining their consumers really well. So consumers, in the red bar, you can see the consumers who are shopping before COVID-19, they remain shopping over there during COVID-19. So they didn't escape from those 2 types of stores. However, consumer actually escaping from farmer markets and wholesale club. Those numbers are represented by the blue bar. You can see those blue bar represents consumers who used to shop in those places before COVID-19. However, during COVID-19, they stopped shopping over there. So therefore, of course, more public policy in terms of supporting those business sectors. So that's the in-store consumer shopping kind of finding. And now we're going to the online grocery shopping. So during COVID, we're saying that 60% of the US population or 60% of our respondents are utilizing online grocery shopping during COVID-19. And overall, we see that 26% of them are actually first users of delivery services. 25% are actually first-time users of pickup services. That's based on the 2,400 overall sample. Okay, so actually, COVID is a kind of opportunity for those consumers as well because they learn a new skill to ease their life in the post-COVID sections. I'm also learning a lot of new things during COVID. For example, I have my first grocery delivery to my door during COVID. It's my first time using WebEx during COVID. My school used Zoom in our daily education teaching activities. And here is the by platform analysis for the usage of online grocery shopping. We're seeing that although you can see here Amazon Fresh, Walmart, and Instacart, those 3 are kind of the leading players in terms of the online grocery shopping platforms. The largest bar is actually other. So we actually do not know what are those platforms are. Therefore, we say we are actually looking at a very highly competitive or nearly perfect competitive situation of the online grocery shopping platforms. Therefore, if you want to invest in any of those platforms, you have to be extremely cautious, and consumers have to be extremely cautious as well, because if any of those smaller platforms ask you to store money over there for future purchases, you have to carefully investigate or understand if this is a reliable and credible platform. So that's our findings for the online grocery shopping part. So the ongoing research we're planning to hopefully complete soon is about the food secure and food insecure population. So overall, we find that in general, both food secure and food insecure populations, they reduce their frequency to go to in-store grocery shopping. However, food secure people, they can afford or they're willing to spend more money in terms of purchasing food items. But food insecure populations, they are not spending more than before COVID times. Therefore, they have this kind of worry if they're getting enough food supplies in their household, and it calls for more public policy activities. And we also added other variables, including geocoded variables in terms of infection rate, death rate, socioeconomic variables, and the food desert census tract. And hopefully we can get more interesting findings from those new variables to enrich the entire pipeline. So that's it for my research, for our research, sorry. And thank you all for your time. And thank you for having me. So,
thank you, Yiru, for that really interesting presentation. Look forward to hearing more about your results, and I'm particularly would be interested, I don't think this is part of your study, is to see if the sort of some of the switching that has occurred to online delivery and online shopping and grocery delivery, if that continues post-COVID, or whether we're going to see permanent changes post-COVID. But thank you. Our next presentation, I'm hearing some feedback. So our next presentation is by Damion Grasso, who's Associate Professor of Psychiatry. He's the project PI. His presentation will be on cumulative pandemic-related adversity moderates change in affective symptoms from pregnancy to early motherhood in a primarily Hispanic low-income sample. Go ahead, Damion.
All right, thank you so much. It's a pleasure to be part of this panel, and I'm excited to share some findings and hear about others' findings. Let's see if I can coordinate this. All right, so like many of you, back in late March, my research team and I became interested in studying the effects of the pandemic on families and mental health. And of course, there's a history of researchers studying the impact of natural and public health disasters, but few opportunities really to study something at this magnitude, where we've really experienced a dramatic shift in how we interact socially, how we work, how we take care of our children, education, social norms, you name it. And these shifts are no doubt interrupting for many families, while perhaps also creating opportunities for positive change in others. I'm sure you're aware already there's been numerous studies reporting increased prevalence and severity of mental health problems across different populations. And we know that families facing the most risk are probably those with pre-existing challenges, including domestic violence, which we know has increased, financial insecurity, food insecurity, health disparities, or other circumstances that put them at higher risk for infection or adverse consequences because of these changes we're experiencing. So back in March, in thinking about measures that we wanted to implement in our own research with our populations, there were a few cropping up, and we found that none of those we were coming across did a particularly good job at systematically measuring specific experiences on daily life and functioning. Rather, these measures seem to focus more on measuring perceived stress and perceived impact, which is an important component of this. But because this is all pretty new, we have no idea how specific experiences or patterns of experiences are linking to mental health and social emotional functioning. And so we set out to develop a measure capable of assessing these more specific types of experience. We call it the Epidemic Pandemic Impacts Inventory, or the EPI, and the purpose here to assess tangible or objective experiences of the pandemic across different personal and social domains. The primary EPI consists of 92 items, only because we cut ourselves off at that point, which we constructed with a team of clinical and developmental psychologists with expertise in trauma assessment and child development and coping. We also saw input from a variety of professionals in other disciplines, including social work, anthropology, pediatrics, education, and others. When we finally launched the EPI, which was included in the NIH disaster research repository, there was a pretty immediate uptake in usage, and now we have well over 125 research teams using it nationally and internationally. And this is exciting, especially because several of these teams have signed up to participate in a consortium we're leading to pursue opportunities for pooling data and effect sizes and looking at differences in rates across different populations. This slide just shows an outline of the domains covered by the EPI and some of the supplemental modules we created. The main EPI assesses experiences that pertain to work and employment, home life, social activities and isolation, emotional and physical health and infection, and positive change that cut across these domains. And an important addendum assesses pandemic-related experiences of racial and ethnic discrimination. And you'll see examples of some of these items in subsequent slides. Just quickly, this isn't pertinent to the study I'm focusing on today, but we've worked with several other colleagues within and outside of UConn to develop supplemental modules for assessing these experiences specific to healthcare and mental health care, as well as the perinatal environment. We have a self-report version for adolescents as well as for older adults, and you'll hear more about that in the next talk. All versions are translated into Spanish, and we have the main module also translated into a few other languages as well. The study I'm going to talk about today involves a subsample of women who originally participated in a larger study that I conducted during pregnancy and birth. These were 263 women recruited from a prenatal care clinic in Hartford. The goal of that study was to examine the intergenerational transmission of trauma-related risk in epigenetics. In that study, women completed a battery of measures in their third trimester, and biological samples were collected from mom and from newborn infant at birth. It's a pretty high-risk sample. More than 80% reported a PTSD qualifying trauma at some point in their lifetime during when they reported on this in pregnancy. About a third also reported experiencing domestic violence in the past year. In terms of demographics, about 3/4 of the cohort identified as Hispanic, and almost all reported low income or receiving public assistance. Just briefly, in a series of studies from that study, we showed linkages between maternal adversity and mental health functioning during pregnancy, which is also associated with stress-related epigenetic patterns, both in mothers and in infants. For this InCHIP funded pilot, we returned to the cohort to recruit a subset of women willing to participate in a follow-up survey. Among the 249 in our repository, we had reliable contact information for 129. And ultimately, 57 women, about 47.5% of those invited, completed this survey. Children ranged in age from 9 months to 5.6 years. And so these women participated in the baseline study at different time points. The subsample was about 90% Hispanic and also low income. Several measures included the EPI, a trauma history form, a measure of maternal negative affect, emotion dysregulation, PTSD symptoms, parent sense of competency, and child behavior problems. The negative affect and emotion dysregulation measures corresponded to measures that were implemented during pregnancy, and so this allowed us to look at change over time. We had 5 research aims to examine rates of pandemic-related experiences across social domains in this low-income sample and to compare them to rates from a higher income, predominantly non-minority sample that we recruited in a previous study, survey study of individuals living in the Northeast region of the United States. We wanted to examine associations between maternal symptoms during pregnancy and pandemic-related adversity, both cumulative experiences and critical experiences that included conflict in the home and changes in mental health treatment during COVID. 3, to test associations between pandemic-related adversity on the EPI and concurrent maternal symptoms, perceived parent competency and child behavior problems. To test whether cumulative pandemic adversity moderated change in maternal symptoms from pregnancy to COVID. And then finally, to test whether cumulative pandemic adversity moderates associations between maternal symptoms during COVID and child behavior problems. In these next slides, I'll present rates of endorsement of EPI items across domains and you'll get some sense of the content of the items. I'm going to go through these fairly quickly in order to stay on time. The red bars in the graph represent a maternal sample from the pregnancy cohort, and the blue bars represent the higher income Northeast sample. I won't mention all the differences, but the red text represents items in which the maternal sample endorsed significantly higher rates, whereas the blue text represents the opposite. In this particular domain, the maternal sample endorsed more layoffs or furloughs, reduced work hours, and having to continue to work despite higher risk of infection. The home life domain measured changes in the household as well as economic challenges. Here we see that the sample of mothers are reporting more difficulties taking care of children in the home and needing to take over teaching. We also see higher reports of difficulty accessing healthy food, paying bills, and accessing transportation. The social activities and isolation domain include changes in social interactions with family and friends, issues related to quarantine and isolation. With more older adults in the Northeast sample, we see higher rates of some items that likely reflect greater risk for older individuals. The emotional and physical health domain covers changes in mental and physical health, lifestyle, and experiences with mental health and medical treatment. Here we see a higher rate of increases in child mental health problems in the maternal sample relative to the Northeast sample. 8 items assess issues of COVID testing and infection. We had low rates on these items in both samples, but perhaps this would look different if we were to do this survey now or later. Another domain captured positive change. Interesting to note here that most participants endorsing adverse experiences also endorse positive ones, so they aren't mutually exclusive. Here you see the maternal sample reporting higher rates of positive change having to do with more time spent with their children and some increases in healthy lifestyle behaviors. This is the addendum that measures experiences of racial and ethnic discrimination. We only measured this in the maternal sample because it wasn't ready for the previous sample. Although there's fairly low rates on these items, it's notable that my sample is limited by sample size and also had very few African American individuals who may have responded differently to these items during this period. In terms of prenatal symptoms predicting pandemic-related experiences, we found that prenatal emotion dysregulation predicted increased conflict in the home, measured in the home life domain. We found that increased conflict was associated with greater negative affect and less perceived parental competency in mothers during COVID. We found that cumulative pandemic adversity in the emotional and physical health domain was associated with greater negative affect during COVID in mothers. And also, interestingly, unfavorable changes in mental health treatment because of COVID, either treatment stopping or going virtual, was associated with greater maternal PTSD, negative affect, and greater child behavior problems during COVID. In terms of predicting child behavior problems, maternal PTSD during COVID and greater negative affect of mothers predicted increased behavior problems in children, but we didn't find this for maternal emotion dysregulation, and there wasn't any moderation by epi experiences. When looking at change in maternal symptoms from pregnancy to COVID, total pandemic adversity on the epi moderated change such that more adversity was associated with increases in negative affect from pregnancy to COVID. This wasn't the case for PTSD or emotion dysregulation. And in conclusion, we found high rates of pandemic-related experiences in this high-risk, predominantly Hispanic sample, with some evidence of higher adversity in the maternal sample relative to a non-minority higher income sample living in the Northeast of the United States. In particular, we saw challenges with increased challenges with loss of work, childcare, finances, accessing healthy food, and increased child mental health problems in the maternal sample. We found evidence that pre-existing caregiver symptoms, in this case emotional regulation during pregnancy, may be predictive of families that go on to experience increased conflict during the pandemic. This suggests that emotion regulation and perhaps relational skills may be important targets for preparing families to better tolerate and manage challenges associated with a pandemic. We found evidence that cumulative pandemic adversity and specific experiences of conflict and disrupted mental health treatment were associated with poor psychosocial outcomes for both mothers and children. This highlights these as an important area to address for public health outreach for vulnerable families. Finally, we found evidence that cumulative pandemic adversity serves to moderate change in negative affect from pregnancy to later motherhood. And this, I think, underscores that these adverse experiences can add up to compound risk and influence functioning in caregivers who are already facing significant challenges. Notable limitations, I already mentioned that this is a small sample size, but a pretty vulnerable population and important to understand. Because of the sample size, we weren't able to apply more sophisticated analyses, such as person-centered latent class analysis, which we did apply for the Northeast sample. And that technique would have maybe provided a more nuanced picture because it can identify profiles of experiences that are associated with risk. Here, we used a cumulative count of experiences. All the experiences were weighted the same, but was still statistically robust in linking to some of these outcomes. I want to thank you for listening. I want to thank InCHIP for the funding for the pilot study, all my collaborators who helped develop the EPI and who are involved in other work. And I'm interested to hear the rest of the talks. Thank you.
Thanks so much, Damion. That's a really important study, and we look forward to hearing more about it and sort of where you plan to go with next steps. Our next presenter is Kevin Manning, Associate Professor of Psychiatry. He's one of the co-PIs on this project. This is another multidisciplinary team. The other co-PIs are David Steffens, Professor and Chair of Psychiatry, Lihong Wang, who's Associate Professor in Psychiatry. Additional co-Is are Grace Chen, who's an Assistant Professor in Psychiatry, and Rong Wu, who's a Research Associate at UConn Health Connecticut Convergence Institute's Biostatistics Center. So, Kevin Manning, it's all yours.
Thanks for the introduction. And I'm really happy to be here and talk to you about some of the research that we've been doing. Yes, so I was very fortunate to collaborate with Dr. Steffens, Dr. Wang, Dr. Wu, and Dr. Chen, but also Dr. Grasso, who did a great introduction to the EPI and was very gracious enough to let us use the EPI in our own research. And I'm going to talk to you about some of the results that we have there. But just some background first. It's really unclear how the COVID-19 pandemic will impact the mental health of older adults in the long run. There's certainly been some speculation about pandemic-related increases in depression and anxiety due to obvious social isolation, the stress of potentially getting this illness, but empirical data are lacking. And older adults with a history of major depression may be especially vulnerable to pandemic-related declines in mental health for a number of reasons. One is that older adults with major depression are susceptible to perceived stress. Stress is a risk factor for future cognitive decline in older adults, as well as depression relapse. Older adults with major depression also, by and large, have larger scores on personality measures related to neuroticism, which neuroticism conveys a vulnerability to stress and anxiety and depression. And then finally, older adults with major depression have cognitive difficulties, cognitive weaknesses in executive functioning, which might interfere with their ability to regulate emotions. By contrast, there's this construct of psychological resilience, or the ability to cope and bounce back from stress, that might act as a buffer against the psychological impact of COVID and these stressful times. So here's a bit of a model of the work that we do, and if I could draw your attention, down to the bottom. Right now, we're focused on acute and chronic life stress, as well as buffering of factors like resilience, and how that stress relates to depression and brain changes and cognitive decline in older adults. This was really a snapshot, so I'm going to focus more on depression and anxiety scores and scores on the EPI, and also share some resilience data as we progress. So our aims were to investigate the association between COVID-related stressors and depression and anxiety in older adults with a history of major depression, to really first determine what's the relationship at this one snapshot in time between depression, anxiety, and EPI stressors. And then we began to explore really the construct of resilience. And does resilience seem to buffer the impact of COVID-related stressors on depression and anxiety in older adults with a history of major depression? Dr. Grasso did a wonderful job of going through the EPI. It's a 92-item survey meant to assess how the COVID-19 pandemic has changed people's lives in 10 different domains. We were particularly focused on social support, physical distancing, and also positive change. There was a very low incidence of infection. There were actually only 5 subjects in our cohort of about 42 who knew somebody who passed away from the disease. And Dr. Grasso already went through some of these items, but I figured to show them again because we're going to be talking about these scales in particular. So the social activity scale, examples include separated from family or close friends, did not have the ability or resources to talk to family or friends while separated. Then there are physical distancing and quarantine measures, isolated or quarantined due to possible exposure, isolated or quarantined due to fear of the illness, due to symptoms of the illness, and then also positive change, more quality time with partner or spouse, more quality time with family or friends, more quality time with children, improved relationships, and so on. I'm also going to be talking about resilience. We measure resilience in our laboratory with something called the Brief Resilience Scale. This is created by colleagues at The Ohio State University, and it's really trying to get to the construct of your ability to bounce back or cope with stressors. So higher scores indicate more of that ability, in other words, to cope with stress. For example, it does not take me long to recover from a stressful event. I usually come through difficult times with little trouble, so on. And what we were able to do in our research is to implement the EPI, a slightly modified version for the geriatric population, into the neurobiology of late life depression, or NBOLD study. And NBOLD began enrolling depressed and never depressed adults in 2013 and currently follows 77 depressed or previously depressed older adults and 22 older adults who were never depressed. And subjects are well characterized in a variety of domains. They undergo an extensive neuropsychological battery. They undergo structural and functional imaging. They also complete a wide measure of personality, social support, stress questions, including now the EPI. And we actually follow people longitudinally, and I should say annually, I mean. And so every year they undergo a very comprehensive assessment. And so what we did was, so far we have administered the EPI to 42 older adults who previously entered the study with a diagnosis of major depression. They're now in about years 3 to 5 of the study. So by and large, this cohort is not clinically depressed. When they come into the study, they are offered treatment. Many of them are already involved in treatment from other sources. So we do a fairly decent job of treating them. So they're not depressed. But this cohort of older adults with major depression is at risk for relapse and is still at risk for cognitive decline. And so what really just wanted to establish was, well, how does, in this snapshot, how does ratings of depression and anxiety correlate with the EPI scores? And higher scores for depression and anxiety mean greater depression and anxiety. So higher is worse. And I'll share a couple of things that were first surprising to me. So if you look at these data, at least for the depression scale, higher depression was associated with less stress in terms of social activities and less stressors related to physical distancing. So in other words, it seems from this story that those who are doing the most physical distancing, the most restriction of their social activities, actually experience less depression and anxiety. But what I'll show you on the next slide is that, getting into the nitty-gritty of the data, it finds that so many of our subjects are not reporting depression anymore because they've been treated, that there's really a very small subset of this 42 individuals where we do see a positive association between depression and stressors on the EPI. By contrast, folks who are reporting stress in economic domains, in physical health domains, they are reporting greater anxiety. And it was interesting also to see that those who are reporting positive change are reporting less depression and less anxiety. And so here's just sort of making home the point that if we look at this sort of green ellipse at the tops, we are seeing a positive association between stress related to social engagement and depression. But by and large, many subjects in our study are no longer reporting depression. So thoughts for us for future analyses. And what we did next was we broke the groups up by resilience. So simple median split on this brief resilience scale from Ohio State. And we looked at two groups of individuals, those with high resilience, those with low resilience. And it was interesting to see that individuals who scored high in resilience, not only did they report less depression, less anxiety, but they also reported more positive change as a result of the COVID pandemic, despite no group differences in other very important domains like physical health changes, physical distancing, social restrictions, and so on. So that just gives us ideas for future targets. Dr. Grasso was talking about emotional regulation as one possible mechanism. There's an increasing literature about ways to strengthen psychological resilience in different populations. And so that's something that got us thinking about what can we do to really strengthen the resilience of our cohort as a way to potentially buffer against stress and improve depression and anxiety. We're very much interested in, really conducting some complex longitudinal analyses. So we have this pre-cohort of NBOLD who have these annual scores of cognition, personality, imaging. We've started to give the epi. We will continue to give the epi in this cohort. And so down the line, it'll be very nice to conduct some longitudinal analyses and potential mediation and moderation. I really wanted to mention, but thanks to InCHIP support and Dr. Grasso's support, we were able to submit a RL1 that we recently received a score on. Dr. Steffens submitted a renewal for the NBOLD cohort. Happy to say it received a high score, and we think we'll be able to continue to follow this cohort for the next 5 years, examining these relationships between stress, chronic stress, personality, and depression. I already mentioned my colleagues, Dr. Steffens, Dr. Wang, Dr. Wu, Dr. Chen. Again, much thanks to Dr. Grasso, and thank you, Debbie and Amy and the rest of the InCHIP group. This was a great study for us, and we appreciate your support. So thanks very much.
Thank you, Kevin. We're fingers crossed that you do get continued funding. Very important study about stress and resilience among older adults. Now I would like to shift gears. Katie Weber, who's a doctoral student in communication and co-PI on this project, will be making a presentation. There are 4 additional co-PIs on this study, including Sarah Stefano, who's assistant professor in communication, Sharday Davis, also assistant professor in communication, and Stephen Stefano, associate professor in communication. The title of the presentation is Staying Alive, using the health belief model to understand persons of color intention to wear masks during the COVID-19 pandemic. Katie, it's all yours.
Thank you so much. Can you hear me okay?
Yes.
Okay, great. Thank you again to InCHIP for giving us this opportunity, and thank you again to my awesome faculty members and mentors for jumping onto this project with me. So this tweet here says, I don't feel safe wearing a handkerchief or something else that isn't clearly a protective mask covering my face to the store because I am a Black man living in this world. I want to stay alive, but I also want to stay alive. This was posted by Aaron Thomas in early April. He wasn't a well-known individual until he made this tweet, which went viral. He was showcased in major news outlets, the Boston Globe, Good Morning America, things like that. because what he was saying was, as you can see by this tweet, it was retweeted, it was requoted, it was liked. People were really resonating with this idea that the fact that he is a Black man, he does not feel safe during this pandemic, having to cover his face. And a caveat of that also is that this, right when we were creating this proposal for this presentation, was when there was not a lot of availability of masks. So we were kind of saving the PPI stuff for the frontline workers and stuff. So it was really up to, you know, the lay people to find bandanas or other ways to cover themselves. And the other thing that motivated my interest in this study is just the prevalent past and present racism and xenophobia in this country. So research shows that white Americans tend to associate criminality with people of color, and that they believe that most criminals come from racial minorities. Also, members of law enforcement tend to stereotype Black, Latinx, and other racial minorities as criminals, violent, and dangerous. And this can be seen, you know, kind of in action by current prevalence, but also historical prevalence of excessive force, violence, and death by law enforcement that disproportionately affects Black and brown bodies. And another, you know, interesting aspect of this study that we wanted to consider was the fact that, you know, stereotypically this disease was associated with China. And there has been a lot of racist and xenophobic attitudes toward Asian Americans, most prevalently from, you know, leadership in this country, that then gets reinforced by on a day-to-day basis. So those were kind of the main things that drew my interest to this study. The theoretical frameworks that we're working with, the health belief model is really the core of this study. The health belief model was created in the 1950s by Rosenstock et al., and it's been applied in several different ways throughout the years: early screening for diseases, immunizations, compliance with medical regime, engagement in health-seeking behaviors, and then lifestyle change behaviors like quitting smoking, risky sexual behavior, et cetera. So we were looking to apply this in the COVID-19 pandemic to see how people of color feel about wearing masks, and then all of these pillars of the health belief model, including perceived susceptibility, so how susceptible or how at risk do they feel they are to COVID-19, what's the perceived severity of COVID-19 to them, so how severe will it be if they get that. Also, what are the perceived benefits of wearing a mask or engaging in behaviors that will prevent you from getting COVID-19? What are perceived barriers to wearing a mask? And then taking into account modifying variables such as demographic information, psychosocial information, and those things include, you know, like race, gender, location. Psychosocial includes things like social class, health history, et cetera. We're also interested in cues to action. So cues to action can be internal or external. So internal might be, are they having symptoms? External would be something like, what's the media saying? What is my family and peer group saying? Self-efficacy was added to the model in the late 80s to account for understanding the perspective of individuals' ability to comply with whatever that health behavior is. So how, what we particularly looked at was how able do people feel like they are to comply with general health behaviors that are helpful for COVID, but also like washing of hands, wearing masks, et cetera. And one limitation that's been noted in several meta-analysis of the health belief model is that the model doesn't take into account certain emotional aspects. So that's something that we wanted to address by measuring various levels of emotion. And then also there are oftentimes other factors that could influence a lot of these behaviors, one of which leads me to the other framework that we're working with, which is social identity threat. And social identity threat is kind of situated inside of the social identity theory, which in short, the theory suggests that individuals strive to maintain a positive perception of groups and collectives, and that someone's social identity is really just how they perceive themselves in their relevant group membership. So a threat to someone's social identity involves instances in which individuals feel the groups at which they belong to have been evaluated negatively. And feeling like there is an identity threat against a person can lead to negative psychological and behavioral outcomes, and that can be anxiety, depression, general health behaviors like sleeping and eating can have issues, and decision making, And then also a sense of belonging and interpersonal relationships can be affected as well. The key one that I wanted to focus on was the manifestation of negative emotions or reinforcing behaviors that align with group norms. And this comes from the idea of vigilance that's heightened during feelings of this social identity threat. So social identity threat is associated with hypervigilance of anticipating a stigmatizing event in context where previous experiences of stigma were sustained by someone else or others. So what that means, generally speaking, is if you're in a group, let's say you're a Black individual, you're an Asian individual, you're a Latinx individual, and you know that historically speaking, you or people that you know, people in your group have experienced some sort of stereotypical interaction to that identity, that's going to kind of prime you to feel a certain way when you're out in public, when you're wearing a mask, for example. So some of those types of things. This is the health belief model with our variables attached to it. So as you can see on the left, there's like the demographic, the psychosocial, all of those aspects of the health belief model in the middle there. And then also over to the right-hand side, hopefully predicting their intentions to wear a mask. These were our hypotheses. We hypothesized, the first one is that Asian individuals will experience higher perceived susceptibility to COVID-19, perceived severity of COVID-19, perceived benefits of wearing a mask, and self-efficacy in wearing masks, while also experiencing lower perceived barriers to wearing masks compared to their Black and Latinx or Hispanic counterparts. The second hypothesis is that men will experience higher perceived susceptibility to COVID-19, perceived severity, perceived barriers to wearing a mask, and lower perceived benefits of wearing a mask and self-efficacy in wearing a mask. The third hypothesis states that stronger racial group identification will increase perceived susceptibility to COVID-19, perceived severity, perceived barriers to wearing a mask, decreased perceived benefits, and self-efficacy. The fifth is that individuals with more pre-existing health conditions will experience higher perceived susceptibility, perceived severity, perceived benefits of wearing a mask, and self-efficacy in wearing it, while experiencing lower barriers to wearing the mask. And then the last one that we tested, or that we've looked at so far, is that the type of face mask, so is it an N95, is it a bandana, is it one that your mom made for you? The differences between the masks that you are wearing will also affect those health belief models variables. So on the right, you can see the mask photos that we chose. So one of the questions that we gave was, which mask do you have access to? What is the one that you wear most frequently when going out in public? So they had those options to choose from. We collected data in the middle of May. Our goal was to have about 500 participants, which we did. And we used quota sampling by race and gender. We asked quantitative and qualitative items. We asked them, again, what mask they had access to and what they wear. We asked self-reported health status, behaviors, such as sleep, exercise, eating, and also previous diagnoses, particularly ones relevant like asthma and things like that to COVID-19. We also asked them religious and political affiliations, their media preferences, again, emotional responses when wearing masks. And then we asked them health belief model variables, particularly related to COVID-19. And I put the alphas there so you could see that those are all pretty reliable scales. We also asked them experiences of everyday racism. So, it was a 1 to 7 scale of interactions that they have with individuals in their everyday life that they perceive as racist. And based on that, we asked them how vigilant they feel, or we asked them measures on a heightened vigilance scale. So are they more concerned? Are they more worried when they go out? Are they worried that people are going to interact with them in a certain way? So things relating to being vigilant while they're out in public. And then lastly, we asked them about racial group identification. So how strongly they identify with whatever race they chose on the initial, at the beginning of the survey. So Black, Asian, Latinx, Hispanic. Quickly to go over our sample characteristics, we had an even split for the races, gender, income here, which is something I'll talk about a little bit more in the limitations, but most of our participants, or the highest amount of our participants, fell into making 10K and under, or making 90K and above, which again, we'll talk about that. I'll talk about that in a little bit. Also, education. Most of our participants had at least a bachelor's degree. So again, a highly educated sample. Political affiliation, most aligned with feeling like they were Democratic, but then as far as their political beliefs go, they leaned moderate. So as far as the health belief model variables go, you can see here that they were all correlated with one another, which is good. That's what we were looking for. And you can also see, interestingly, that the means are good. So, the benefits, self-efficacy, behavioral intentions, those means are all pretty high on a 1 to 7 scale, which is good. And then the barriers to wearing a mask is relatively low on a 1 to 7 scale, which is overall a good thing. In our preliminary analysis, again, we're not really done fully, fleshing out these, but so far H1 was not supported, and there's not a group difference, and we're assuming that there's probably a third variable at play. H2 about men versus women was also not supported, and it was actually in the opposite direction. Women perceive themselves to be significantly more susceptible to the disease. Men and women did not differ on any other constructs. Hypothesis 3 was partially supported. Group identification was relatively high for all groups, but only strongly identifying as Asian was particularly related to increased perceptions of susceptibility and severity. H4 was also partially supported. More experiences of everyday racism, increased severity, and barriers to wearing masks. And H5 was partially supported as well. We worded it as previous diagnoses of pre-existing conditions, but our sample didn't really suggest that they had many. So instead, we looked at their self-reported perceptions of physical and mental health, and higher frequency of poor physical health days over the past month was associated with higher perceived susceptibility, and they also perceived the virus to be more severe. And also, and almost more interestingly, which speaks to some of the other presentations, is that higher frequency of poor mental health days over the past month was associated with higher perceived susceptibility to the virus, perceiving it as more severe, perceiving more barriers of wearing a mask, and perceiving lower levels of self-efficacy related to the COVID-19 pandemic. And then lastly, the differences in masks, there were no differences in wearing masks. So discussion and future exploration of our data. A couple of things to note as far as limitations so far is that most of our participants had relatively low experiences of everyday racism, which is great. But I think a lot of that, if I had to speculate, has to do with the sample that we have, which is highly educated, higher income, et cetera. Most participants, when we asked them if they'd ever been stopped, so again, we also asked qualitative questions, which I didn't mention because I'm not going to talk about them, but we asked if they had been stopped or had experiences with, police or anything like that, and most people had not. Most people also reported that they wear masks, which is good. And we may have missed the window. There was obviously a lot going on in May between George Floyd's murder and kind of the first peak of the coronavirus, where it could have just been off timing with when we were trying to capture the data. And another aspect that would be interesting to look at would be perceptions of others wearing masks, right? But we really think that what's important is the aspect of those who are, the historically marginalized group and understanding their perspective. What we have left to do is model the data onto the model that we showed you, explore vigilance more because it was correlated with a lot of these variables listed here. Look at potential moderators or mediators of political affiliation, religious affiliation, looking at those emotional responses, and then also looking at geographic location. So in a quick look over of the results, we have at least 40 states represented. So we also collected their city. So I'm interested to kind of compare rural versus city and things like that. And then I just wanted to share this other quote from Aaron Thomas, who says that there is still nuance of race that dictates our lives and the way we move through spaces, even in these turbulent times. And I think that this quote kind of summarizes, again, why we were interested in this study and why there's still more exploration to do. So thank you to InCHIP again, and thank you to my co-authors, and thank you all for listening.
Thank you, Katie. That's a really interesting study, and it would be fascinating to see what has happened since then as mask wearing has become even more politicized and et cetera, et cetera. So really interesting study. We're going to finish up our panel discussion with Blair Johnson, who's a distinguished professor in psychological sciences and one of the co-PIs on this project. The other co-PI is Mary Bernstein, who's a professor in sociology. And they have additional team members, Kun Chen, who's Associate Professor in Statistics, is a co-I, as well as Emily Hennessy, who's an Assistant Research Professor, and Becky Akubchuk, who's an Adjunct Professor in Psychological Sciences. So I look forward to hearing your presentation, Blair.
Thank you, Debbie. I added a subtitle because these are preliminary findings and focus us onto the state of Connecticut, and actually it follows nicely from the talks that have come before. So I'm happy to be here, especially because of that. I also added two co-authors, Christine Curley and Lizette Martinez-Berman, are graduate students with me in psychological sciences. So let me start with acknowledgements. You already know our departments, but we've had 3 different grants, 2 of them from CLAS and 1 from InCHIP, to support the work that you're going to see today. So back when the pandemic had just hit, gun shops were deemed essential. And you saw not only runs on grocery stores, as you witnessed earlier in this series, but also on guns. And it, of course, caught our notice because we were already doing research on this issue of guns in America and violence in America. And the question is there a new syndemic that can be labeled? So the work that we had been doing was modeling gun violence at the county level in the U.S. So here's 1 year of gun violence in the U.S., and where you see darker counties, that's where you have more gun violence. We model that, and we end up showing that where there's a lot of income inequality, minorities are especially likely to experience. Those communities are more likely to have gun violence. Where you have poverty side by side, high income, that's where you see a lot of gun violence. And actually, gun laws work where you have more urban environments, maybe less so for rural ones. So we're taking an ecological perspective on this, and we think of the ecological factors as relating to stress on the ground, which then makes people more susceptible to engaging in gun violence. So back about a year ago now, we asked this question: why not model gun violence with finer spatial resolution? And so we decided, well, let's study our state. So here's gun violence in Connecticut over 5 years ending in 2018. And you can see where there are true hotspots, where these are the ones that are probably the most famous for gun violence. So it confirms that. These data come from the Gun Violence Archive, which pretty much day by day records gun violence in America and makes the data set available to researchers to use like us. We model them using things like you just saw with the national level data. And after we model them, we've got these town level effects. These are like residuals, where things are hotter than they should be or lower than they should be. And the green ones are of interest because we might learn something from those communities. Like, why is it that they do so well with gun violence? And we might learn something from the other communities that are worse than they should be. And maybe we get clues from this. The green spots actually are interesting too. One is Yale in New Haven, where the main campus is, Danbury, Waterbury, and then the one just south of us is Willimantic. So we followed this up with purposive sampling of spatial residuals. So we're essentially going into those communities and surveying them, with the questionnaire that we designed. And so you can see there, we went into hot spots, cool spots. Qualtrics is the surveying here, and you can target individual zip codes. So that's what we did. And then we also sampled towns that border either hot or cold spots or both, and none of the above. So you're getting maybe about a third of the zip codes in Connecticut when you do this. And so we were in the field right when the pandemic hit. And we went in with the InCHIP funding, and we were in the field right when the first shutdown period was ending. And now we went for the whole state. We didn't restrict it just to the ones of interest to start with. So the pandemic is much larger than the gun violence epidemic, I suppose. And you can see we managed to get 247 people to repeat from the first wave. So there's a repeated measures aspect to this one too. So in wave 2, we managed to get 71% of the towns in Connecticut. And the ones that aren't in there tend to be smaller, less populated places. So probably less interesting. And then very broadly, here are some variables that we investigated. I'll tell you more specific about some of these, but we had a community health perspective in the first place, so this is all very relevant to COVID. And so mental health, loneliness, and community capital, perceptions of violence. We added COVID-19 perceptions and protective behavior for wave 2. Gun ownership was in both. Purchases we didn't put in the first one, we have in the second. And then we had feelings about America and minorities in both waves, and of course demographics. So there's a broad overview of what we've done. There's a lot more than that for interested parties. Broad demographics, this looks a lot like Connecticut, except for it's tilted more towards women. Otherwise, most of the people are for middle-aged or older. About half are married, and most are white. And we asked in wave 2 about essential workers, and almost a third of people were essential workers. Okay. So is it related to, is the pandemic related to guns? Interestingly, what you tend to see is that people judge that their communities had less support of guns in May than they did back in March. But they judged that guns being used for protection was more of an emphasis. These are significant differences based on the repeated measures, by the way. A quick note, these are all put onto a 100-point scale for ease of interpretation. They're POMP scored. I guess the nice part about this one is that all these mean values that you see here are less than 50, which is the midpoint. Okay. Have you experienced gun violence? There wasn't a change between wave 1 and wave 2. That's a nice thing to hear. And then just as a descriptive statistic, about 15% of the surveyed people bought guns and or ammunition during the period before the survey, after the pandemic hit. Is it related to coping, the pandemic? Well, people thought that it had disrupted their lives. So over 60% said that it had disrupted their lives, that major life events were being disrupted, that it was preventing them from going to weddings and stuff like this. We also had the DAS in here, so depression, anxiety, stress, and indeed that increased during this period. Loneliness increased during this period. And pain actually stayed the same. If anything, there was a slight decrease, but it wasn't significant. We also correlated these measures broadly. So across the top, you've got COVID-relevant stuff, and then the mental health, a couple of the mental health ones. So we had an index of safety, which is things like mask wearing, gloves, distancing, et cetera, the things that were being advocated at that point. And those are all negatively correlated with the gun stuff, and actually positive with the psychosocial dimension of immigrants being good. Right? So I'll come back to that one in a minute. People judged how disruptive their lives were, and that was only correlated slightly with experiences of gun violence. Did COVID-19 reduce your resources? That's things like financial, you lost your job or your income's lowered. That was correlated with all the gun violence stuff and the culture of gun violence. And it's the reverse in terms of thinking that immigrants are good. And the mental health and the DAS, you see that you've got significant correlations with experiencing gun violence and cultures of supporting guns or guns for protection. And again, the inverse correlation with immigrants being good. Pain was positively correlated with all of the gun-related stuff. So cause and effect here, this is all wave 2 stuff that we're talking about. Well, pretty much I'm presenting these, if I've got it at wave 1, the correlations look the same. So a closer dive on protective behavior and support for immigrants. So we have a perspective and a correlational way of looking at it. So the item is, I feel that immigrants are good for America. So the positive end is on the left and the negative is on the right. Wave 1 does show a significant correlation that is the inverse. So people with the more prejudiced attitudes, if you will, have the worst COVID protective behavior. They're most at risk. And if you do the correlational one, which is more of Connecticut, you still get a significant correlation. It's not quite as sharp. So our gun violence and COVID deaths correlated. I showed you this map to start with. I went to get town level data from the website you see at the bottom of the slide. Scott Gall is he manages that database. And at the end of May, here's what the data looked like. And it was me who made the map, full disclosure. But at least you can see a correlation between heightened red and both of those graphs. So conclusions. The pandemic did have a sizable impact on mental health in Connecticut. Lower mental health is associated with communities where there's more gun support. Conformity to COVID safety guidelines related with lower gun violence risk. And negative attitudes for outgroups are related with both worse COVID-19 risk behaviors and increased gun violence risk. And by the way, we had attitudes for different races, and the very same things were happening with those. Limitations, well, the standard things. This is preliminary, but I'm feeling pretty good about my analyses right now. It's a survey methodology. It's people who are available for surveys. The measures are relatively simple, and they are self-reports. So those are things that are cautions about this. On the other hand, it's a fairly large sample. At least we have 2. Extensions, and if you want to collaborate, you have some interest and you have some time, then contact us. So otherwise, I'll thank you for your time.
Thanks so much, Blair. That's fascinating presentation and raises a lot of questions about what you would do with those findings and how you could potentially intervene. So I want to thank all the presenters for their very engaging presentations. I want to open this up now for questions. If you have a question, you can raise your hand by clicking on the small hand to the right of your name. And I'll call on you, then unmute yourself so you can interact with one or more of the presenters. If we have anyone on the phone, just tell us via phone that you have a question. So feel free to ask some questions. While we are waiting for questions, I'd like to start with, I guess I could direct it to all of you, but particularly Damion and Kevin. So based on your findings, what do you think are some of the implications for interventions to help people better manage their stress and build resilience?
Yeah, that's a really good question. Damion, do you want to tackle that first?
Sure, I can just say that, we know that so many of the community-based services that some of these families receive, including with the Department of Children and Families, domestic violence advocacy groups, child-focused community-based agencies, all have been interrupted in some way during this pandemic, and just now I think are kind of putting resources together to help support families. I think, I think families in my sample and families who before the pandemic really struggled with some of these challenges, I think really depend on those types of services. And so one thing to do in preparation for the next disaster and during this continued disaster is to support those existing services and give them the resources and tools to reach out and continue to serve those families, whether it be virtually or in other ways.
Yeah,
broad-based.
Yeah. I think that's a really good point. And to add to that, finding ways to increase social interactions and social support that are done remotely, I think, is a really important avenue of research. Yale recently published a study not too long ago about where they created a program for medical students who would volunteer their time to give nursing home and assisted living residents a phone call or a Zoom call on a weekly basis. And I just found that a very powerful example of ways that we can engage people who are vulnerable to this illness, but also the effects of this illness from a mental health standpoint. So I think that's the challenge right now, is to come up with some interesting and novel ways where we can increase the social support of our older adults and provide that buffer against physical isolation and that inability to see loved ones and have contact with them.
Blair, I was wondering, I was interested in your finding about lower mental health and gun support. I wonder if you could elaborate on that and speak to how you interpret that.
Yeah. Well, I think you've got to ask what's causing what in cases like that. And so, I mean, we're taking this ecological perspective because we think that structural level events are responsible for a lot of these things. So we think of troubled individuals living in places that are not fostering the most positive psychology, if you will. I would even go further, because it's like Black Lives Matter. I think it's not necessarily of a prejudice. I think that's on the surface of it. The deeper problem is all the things in society that push people into disadvantaged choices. And then they're blamed. It's an instance of victim blaming. Now, our survey, to be clear, or make a little more pointed, is that 80% of them are white, or said they were white. And we didn't have enough of individual races other than whites to focus on them. Just where, looking back, I wish we had oversampled minorities. But it's too late to change that now. But if you look at non-whites as a group, and you look at things like the prejudice and COVID-19 behavior index, that correlation is still there for non-whites. It might not be quite as strong, but it's there. So there's a lot of prejudice going around, and mental health can be everywhere, even in privileged places. So, I think we should ask someone who's a clinician to address those kinds of issues.
Thank you. Other questions? I know there was some bit of conversation in the chat. Marie, I don't know if Marie's still on. She had asked about, and this is Yiru's study about whether there was any assessment of delivered food kits like Blue Apron, HelloFresh, etc. Peter, you had answered that. I don't know if you want to talk a little bit about that, Peter Chen.
Sure, and this is Peter Chen from Geography, and we didn't include that question in our survey because during the early outbreak, we didn't realize it was that popular for food delivery.
Right.
Also, I have a question actually for Katie about the face mask use, and I'm wondering what type of data or geocode data you have in your survey, because you talk about you want to explore the difference in different areas. There might be a difference in face mask use because of the severity of the disease.
Yeah, that's a really good point too, that I actually hadn't thought about, looking at like the severity of the disease in the areas. But we just asked them what city they're from and what state they're from. So yeah, we're hoping to look at that as far as like you just said, like where areas of the pandemic have been more problematic, perhaps where there have been specific like strong prevalence of like racial issues that have been happening. So looking at all those factors from a location perspective is something that we're interested to do.
In your data?
No, just city, just the city and then the state that they're from.
I think there could be a difference in different cities as well, because in our data we actually geocoded with a zip code, and then we match it with the county level, and we derive the infection rate as well as the death rate at the county level, and we feel that type of the environmental and the health environment may have some influence on people's grocery shopping behaviors, as well as the face mask use. So if you're interested, we can talk about geocoding.
Yeah. Thank you.
Other questions? I'm trying to read the chat too. Sorry. Any other questions? I mean, you can unmute yourself and ask a question. Feel free. You don't have to raise your hand. Well, apparently you did such a great job making presentations. No one has any questions because you've answered them before they had them. So I want to thank everyone for just really interesting presentations. We look forward to seeing what else comes out of your studies and reading any publications that come out of it, and hopefully it leads to additional research. This has been recorded, and it will be posted on InCHIP's YouTube webpage. We have, as I said, our final panel discussion for the year is coming up on November 29th, so don't forget to register for it. And thank you again for everyone, the attendees and presenters. Great job. Have a great week.